Let's start. So let me please start by welcoming all of you, a warm welcome to this Frontline AIDS 2020 event entitled Building Back Better, Adaptations and New Opportunities for the HIV Response during COVID-19. We really thank you for making time during this really busy week, and we hope you can come away inspired and energized. My name is Divya Bajpayee. I'm the Director of Programs here at Frontline AIDS, and today's event is one of three that Frontline AIDS is hosting during AIDS 2020 virtual. And this session, which is called Building Back Better, is part of 3 live events during the conference, based on the themes of our session, of our Sustain, Adapt, Protect call to action, which you've seen on the chat box. And basically it's our call to action on HIV, TB and COVID-19, and which has now been signed, we're really pleased to say, by over 200 organizations working on HIV. So for some of you who may not know us, the Frontline AIDS Partnership has been on the front line of the AIDS response for over 25 years. And we work across Latin America, Sub-Saharan Africa, Asia, Africa, Middle East and North Africa, and Eastern Europe. And you may have known us previously as the International HIV/AIDS Alliance, and we recently rebranded as Frontline AIDS in 2019. So just to set the scene for this webinar, the HIV epidemic is evolving and the disease is spiking, as we know, amongst people in societies around the world with the least power, those whose voices the world continually ignores and who are stigmatized and marginalized just because of who they are. And the most marginalized and vulnerable in society are still the most impacted by HIV/AIDS. Gay, bisexual, and other men who have sex with men, people who use and inject drugs, sex workers, trans and gender non-conforming people, adolescent girls and young women, and people living with HIV are at the core of Frontline AIDS work. And we're really happy to be able to host this event to highlight how the HIV response is relevant beyond HIV. The COVID-19 crisis, despite the devastation it is causing, is also an opportunity for great health systems integration, the people who are most likely to be left behind in reaching universal health coverage and the SDGs. So a bit of details here about the webinar itself. We aim for it to last for about 90 minutes. And during these 90 minutes, you'll hear from 6 invited speakers. But we also want to make sure there's plenty of time for there to be live discussion and interaction with all of you. So that if you want to make a contribution, make comments or ask questions, that you have the time and the ability to do so. And also we'll be able to share all the presentations with you at the end of the webinar to all the participants. So let's just start with the rules for this webinar first. So as you know, it's hosted on Zoom on the webinar function, and this means that attendees' microphones have been disabled. However, we will activate your microphone if you wish to speak. And if you'd like to make a comment, can you please do so by typing your comment in the chat function at the bottom of the screen. And if you have a question for the speakers, please use the question and answer function, the Q&A button, so that we can group similar questions and identify who to unmute to ask questions. And just to remind you all that this is there's live translation during this session. And again, for those of you who've arrived a bit later, please select your preferred language for this session, either English or French, by clicking on interpretation at the bottom of the screen. It's a globe icon. And let me say that in French now for French participants. Veuillez sélectionner votre langue préférée pour cette session, anglais ou français, en cliquant sur interprétation, l'icône du globe en bas de votre écran. Désolé. So just to tell you as well that this is going to be recorded as well. So I think that's all the housekeeping and a bit of background. Let me now start by inviting Pradeep Karkatil to provide the opening remarks. I'm delighted to introduce Pradeep. He's Director in the Office of Innovation at UNAIDS. And as the Director of the Program Partnerships and Fundraising Department, Pradeep oversees programmatic and political partnerships, including UNAIDS' engagement with the Global Fund to fight AIDS, tuberculosis, and malaria, and is also in terms of political and parliamentary engagement and UNAIDS fundraising efforts. Over to you, Pradeep.
Divya, thank you so very much for both the introduction as well as for welcoming me to this session. It's a pleasure and a privilege to be here with you on this session. First of all, I think the topic is absolutely timely. It's about, you speak about building back better, but maybe if I may just add to that, I think for me, it's about completing what the AIDS movement started and to build it through and to complete that, which I think is really a huge challenge, but also a huge opportunity. I've been working on HIV for the last 30 years, and I won't go into too much of the history, but I'll spare you that. But just a little bit, I think the AIDS movement right from day one was about transforming health, as well as it was about equity, it was about rights. And that is what has made the AIDS movement unique in the health landscape. AIDS was always looked at as an entry point to challenge status quo. I think if we look back, what the AIDS movement has really put at the center is that every life matters. There is intrinsic value to human life, and whether you're living in the global north or south, whether you can afford the drugs or not, your life matters, and that they should not be, the price difference of drugs should not be determining whether you can live or not. It was very much about access real time, whether you're in the global north or south. It was access to the best possible treatment and not a differentiated response where you have some drugs that are better, which is available in the global north, and then it takes 8 to 10 years before it reaches the global south. That is what the AIDS movement completely challenged and overturned. It was about ensuring that human life and dignity trumps profits. We have, I'm sure all of us have been out in the streets protesting about profits from various sectors, including the pharmaceuticals. It has been about innovations. It has been about, when I started in 1991, there was hardly any drug. It cost $10,000 per person per year, which most people couldn't afford. And then you also, over the years, you had to take anywhere between 8 to 15 pills a day to live. And today you have one pill which does the same job. Just bring those molecules together, that is innovation. Or you look at social innovations that the AIDS movement has driven, community service delivery, that we have seen works not just for HIV, but it's central to making the health system function. I think the AIDS movement's unique ability to bring the world together, whether you're a civil society activist, whether you're a person living with HIV, whether you're a member state, whether you're a private sector, whoever you are, the ability to bring everybody together collectively to work in the interest of the response has been unique. And those are absolutely lessons that we need to take from the AIDS movement as we look at building the next generation of healthcare. I think my own personal feeling is that the AIDS movement drove a lot of health reform, but at some point of time, we stagnated and we stopped being as ambitious. I mean, the AIDS movement, for me, the best depiction of that is the David versus the Goliath. AIDS movement was the little David, which took on the larger systems and bureaucracies of global health and turned it over. But somehow, once again, and I'm seeing that very much in the COVID response, we are driven by a sense of fear. We have stopped being able to challenge and really to call to account several of the leaders who need to be accountable. And so there are a few broad areas where I think we need to be focusing on when we are thinking about building back better and completing the work that we started. If I look at AIDS movement as the health 1.0 kind of reforms, I do think COVID gives us an opportunity to get to health 2.0. Some of the reforms that we did not manage to accomplish through that movement when we lost our ambition, I think we have an opportunity today. For those of us who were on the in the discussions around the SDG negotiations, health did not find the primacy, did not find the space that we all had hoped it would. It was kind of a marginal, again, I'm speaking this from my own personal experience, having seen some of it, but I'm sure there will be others who will disagree with me. But we didn't get the space. It was not central to development. And what we have seen today with COVID-19 is that if we do not invest, if we marginalize health and the different health movements, including the HIV and TB movement, we will not only lose all the gains that have been made over the years, but the whole economic outlook for the world is going to be very, very challenging. So we have to use this opportunity to once again position health as a right. We need to start demanding health rather than being passive recipients of it. And I think we need to see how we can mobilize the community. And the absolute beauty of the AIDS movement was that it was a bottom-up driven approach even before any of the international organizations or the member states started to take it seriously. I think how can we use COVID to drive a people's movement and demand health as a right? The second thing for me is the universal health coverage. The conversations to date has been basically about access to healthcare, but it has not really defined sufficiently the quality aspects and what that package should include. And I think for the first time, I see this opportunity that we need to be influencing the larger access to health and defining the universal health coverage as a centrality in the development approach. And again, if you look at Africa today, if you look at the COVID response, if you look at all the testing that is happening around COVID or any of the other outbreaks that we have seen, a lot of that is because of the capacities that have been built through the AIDS investments. It has been possible to do what we are doing today, even the effective response and some of the really very interesting response and innovations that I see in communities that is coming is because of our investment in the AIDS response in Africa. And we need to see how we can leverage this and use it as a multiplier when we are talking about universal health coverage. The third area for me is technology and innovation. I think the AIDS movement has embraced parts of the technology and innovation. I think the AIDS movement has been very good in bringing in some of the social innovations. But I do believe that we need to, today we have an opportunity to use technology and innovation to ensure that we can go on a scale, at a speed, and at a reach that would have been completely impossible to think about in the past. It's not going to be straightforward. We live in a very, very fragmented world, unlike what we saw during the early days of AIDS. But I do see huge opportunities. I do see the a history of the genetics of the AIDS movement is now ready to go to the next phase. And I'll stop there, Divya. I can see you now. So I'll stop there, but very, very excited by this opportunity. And I think looking forward to hearing the presentations.
Thank you, Pradeep. Thank you so much for your opening remarks. And yes, I remember meeting you 20 years ago in India, and your reflections are very, very pertinent. You know, it's such a useful frame of how we leverage what have been the strengths and the innovations and adaptations of the AIDS response to COVID. And I love your reminder to us all that the job isn't done yet when it comes to HIV, and actually COVID-19 and the universal health coverage agenda might give us the opportunity to actually finish the job and ensure that the right to health is absolutely kind of at the core of the COVID response and other responses that we are going to have moving forward, and to move it at scale as well. So thank you so much for the challenge and the reminder of where we're coming from, our assets, as it were. Before I introduce the first panel presentation, I wanted to just tell everyone a bit about the Frontline AIDS Global Plan of Action, because we also have a very intentional focus on promising and innovative practices within the AIDS response. And that's from across our partnership. We really think that it's through innovations and adaptations that we can achieve the biggest impact on preventing new HIV infections and stopping AIDS-related deaths among the most marginalized in society. And it's been interesting. I think the COVID-19 crisis has really shown how agile we can be as the AIDS response and how we can quickly move to address the changing needs, and also try and mitigate the threats that people we work with are facing on the front line. Over the last few months, we've heard from across our partners about how COVID-19 has exacerbated existing vulnerabilities within the communities that we work with. But on the other hand, we've also heard about the tremendous resilience and the ingenuity and the creativity that communities have brought to the COVID-19 response. They've really built on their strengths and their experiences working on HIV and taken advantage of new opportunities that have kind of appeared to add value. And that really truly is innovation in action beyond what's written on papers. Truly, that's how innovation we have seen is taking place on the ground. But let me now move us on to the next stage of the webinar, which is to start the panel presentations. And so first of all, it's my great pleasure to introduce Adit Taslim, who is the Executive Director of Rumah Cemara, a community-led organization based in Bandung in Indonesia. And Rumah Cemara is a long-standing partner of Frontline AIDS. Rumah Cemara's work focuses on advocating for national drug policy, meaningful involvement and transparency, running campaigns and education on drug and HIV issues. Adit has been involved with Rumah Cemara since 2005 and is currently serving on the third and his last year as the Asia Pacific NGO delegate for the UNAIDS PCB. Over to you, Adit.
Thanks, Divya. Thank you for the introduction, and thank you, Pradeep, for your opening remark. It really reminds us that there's still a lot of work that needs to be done, particularly in translating what's been agreed at the high level, and how do we make sure that it is translated to the ground and to really make a meaningful impact to people's lives. So thank you for that, Pradeep. So I just wanted to share a little bit on this theme, around adapting with the current situation. So just before I do that, just to quickly introduce our organization. As Divya has mentioned, also we are a community organization that mainly focuses our work around policy and structural interventions, as well as community empowering and community organizing. Though in the past that we've also done a lot of work on service delivery, just that the last 5 to 7 years that we have been focusing more on advocacy, because we thought that it is very critical to also address structural issues and to really make significant changes in where we are in our setting. But like many other organizations, whether it's community organizations, NGO, or even international NGO, or even the UN agency, during this pandemic, we are not ready. And therefore, there has been a lot of very valuable learnings in the last few months that we have been able to see things differently and also to adapt quickly, and to really make sure that we serve our beneficiaries according to their needs. So Rebecca, can you go on to the next slide, please? So just before I share what we've done in adapting to the current situation and also looking forward in this unknown setting of this new world, just to also an important note on where we are in terms of our context. So Indonesia, if you haven't really been following with the progress of Indonesia in terms of the AIDS response, that we have been struggling even before the pandemic. struggling in many areas, in many critical areas such as the 1990 commitment that we haven't really been illustrating the commitment that was as agreed in the 2016 political declaration, with being the fourth lowest country in terms of in the world in terms of treatment coverage. It's really not, I mean, considering Indonesia with its geographical and political power and economy, as well as economy power, I think it's really unacceptable to have that such a very low coverage of treatment, people living with HIV on treatment. Data is also a problem. Prevention has always been a problem, where even before the pandemic, access to condoms and needles and syringes have always been an issue, as well as harm reduction that has been not getting enough attention in the last few years, due to the shift of trend of drug use among people who use drugs. There has been less and less investment towards harm reduction, not only in Indonesia. I guess it's also similar in different parts of the world. But also particularly in the last 2 years, we have been experiencing quite a major national stock out on ARV. From what I observed personally, it has been quite persistent since late 2018. That and it's quite regular that now we have been experiencing some major and really alarming situation on the current national stock on ARV, where people are forced to even change their regimens because the unavailability of their current regimens at the moment. So going to, I mean, based on that context, so when we see our country in responding to the pandemic, there have been several measures put in place by, what I mean is setting policies at the national level and encouraging governments at the provincial and also city level to also follow these new policies and procedures, including decentralizing services, because we know that most of HIV and harm reduction services are also located in major hospitals and clinics who are also main referral hospitals or clinics for COVID-19. And the aim is really to make sure that people living with HIV and people who use drugs are not further exposed with the risk of getting COVID-19, by encouraging health facilities to decentralize their services to other clinics. So that's the policy. Their take-home methadone is also allowed now for 7 days. Previously, in the normal circumstances, it's only been allowed for 3 days. So 7 days take-home methadone has only been allowed for emergency traveling purposes, and it has to be very urgent. And you have to provide a lot of paperwork and some good justification to be able to get a 7-day dose. And from our experience that we have been assisting people who use drugs, we could never get more than 7 days, even for an urgent traveling purposes. And virtual appointment as a policy also has been set up, encouraging health facilities to adapt to the new situation where people don't really have to come to the clinic, but then everything can be done online. As following UNAIDS recommendation, as well as WHO recommendation, that ARV should be provided at least for multi-months. In our case, it's 2 to 3 months, as well as increasing the efforts on monitoring on adherence during this period, and also ensuring that people are still getting access to prevention commodities such as condoms and needles and syringes, as well as the National Social Protection Shield. So that's the policy part. But then when we looked at the reality, then it is really, really concerning, because what happened is that people living with HIV remain exposed because we are still asked to go to the clinic every month. And then methadone for 7 days, people cannot afford to pay for that. People still have to pay 7 times. So on average, what we have to pay is $1 per day for one day of dose. And then if you want to get a 7 days, you have to pay basically $7. And that's really a lot for people who use drugs and for the communities. We still have to go to clinic every month, and then forget about 2 or 3 months supply of ARV. Last month, I was only given for 2 weeks of ARV because we are on stock out since the last 2 years. And it's really concerning, because then with this situation, there's a high potential of increase in loss to follow up. Needle and syringes hasn't been available in the last few years in the clinics, so people haven't really been getting NSP from anywhere. And key populations are being left behind because of the inclusion criteria. Many of us don't have identification. Many of us don't have family certificate, and that's the basic requirements to be able to get the social protection scheme from the government. So Rebecca, can you go to the next slide, please?
Can I push you a bit on time as well, please, Adit?
Yes, thank you. Sorry about that, Divya. So what our response has been really based on the reality. So what we have done is really pushing for a better policy during this time. We wanted to make sure that methadone is free of charge. Methadone is available not only for 3 days or 7 days. That people are also, because peer support workers are still asked to work on the ground, on the field. So we wanted to make sure that they also have access to COVID-19 tests. And we also wanted to use this opportunity to make sure that community-led services are recognized as being an important part of this response. So all the other responses that we've done, including providing support for people to pay for a hospital fees for the ARV refill for methadone, as well as distributing ARV to their homes. I wanted to also go on to the next slide, Rebecca, please. So I guess just to close, I think it's really important that that the government, that's our main ask, that we wanted the government to recognize community-led services as an integral part of the response, not only during COVID, but also in the AIDS response as a whole. And because communities' responses are always based on the needs and the realities of people on the ground, and we are more inclusive because we don't have that administrative requirements, and we are less bureaucratic, and we understand what keep us away and respond to change them, and we are adaptable, and there's a lot of room for flexibility. And when we reach out to our people, we don't just reach, we don't just include the number, but then we make friends. We go beyond reaching. We try to know them. We build trust. We develop friendship over time, and that, I think that's really what make a difference in terms of the importance of community-led. And we have been at the forefront of the response, and we need the recognition. And it is very important that we are being recognized and invested, and also being funded, because we know that communities remain underfunded around the world. So thank you, Divya. I'll turn it back to you. Thank you.
Thank you, Adit. And I think a very important reminder about the importance in investing in community responses as we adapt and as that flexibility and responses based on needs and reality is so critical. Thank you. So now moving on to our second panel presentation, I'm delighted to introduce Masogi Tiandoum, the Technical Director for Alliance Nationale des Communautés pour la Santé, ANCS, based in Senegal. They are also, ANCS is another long-standing partner of Frontline AIDS. Masogi is responsible for the technical management of the programs of the Global Fund, USAID, and the regional program on reducing the risks of HIV and TB and comorbidities in West Africa, and a multi-country project called Adoub, which focuses on access to sexual and reproductive health services for young key populations in Africa. He has a wealth of experience in strengthening community health systems through training, implementation, and evaluation of community-based programs. And he is also very experienced in creating spaces for sharing, capitalizing, and pooling experiences between actors in the community. Over to you, Masogi.
Bonjour, merci à tout le monde. Je voudrais remercier tous les participants, particulièrement Frontline qui a organisé cette session importante. Juste peut-être parler de mon organisation, l'Alliance nationale des communautés pour la santé, ANCS du Sénégal, qui est une organisation de la société civile qui appuie les systèmes de santé, notamment au niveau communautaire, et qui bâtit toute sa stratégie sur la mobilisation des communautés, le renforcement des capacités, mais aussi le développement de stratégies novatrices pour faciliter et assurer l'accès des services de santé, notamment aux populations les plus vulnérables, les populations marginalisées et les populations clés. La pandémie du Covid au Sénégal se présente sur cette situation. Diapo. Alors, la situation du Covid au Sénégal est un peu similaire en Afrique de l'Ouest, avec une forte prévalence dans les villes où il y a beaucoup de population. C'est vrai que la pandémie, l'épidémie en tout cas, ce qu'elle montre en Afrique est assez différent du visage que nous voyons en Europe ou en Amérique. Mais cela n'empêche que les cas que nous avons eus au Sénégal ont plus ou moins affecté le système de santé et l'offre de services. Nous avons très vite été débordés et l'organisation du système de santé au niveau du pays a reçu plusieurs effets négatifs du Covid. Aujourd'hui, nous sommes à peu près à 7 à 8 000 cas et il y a eu 140 décès liés au Covid. Mais ce qui a surtout marqué l'épidémie au Sénégal, c'est que dès que nous avons eu les premiers cas, l'État a pris des mesures pour arrêter l'épidémie ou bien pour ralentir sa progression. Et les mesures que l'État a prises, est-ce qu'on peut voir la diapo sur les mesures? Diapo? Alors, c'était des mesures surtout de confinement, mais aussi d'organisation du système avec la mise en place d'un comité national de gestion du Covid, l'élaboration d'un plan de contingence, mais aussi il y a eu un couvre-feu qui a été instauré et la limitation des déplacements des populations, la fermeture des écoles, et quelques mesures sur le port du masque obligatoire, etc. Alors, ces mesures ont eu comme conséquence d'affaiblir le déplacement des populations et nous nous sommes confrontés très vite à des situations où des personnes, notamment des personnes vivant avec le VIH, qui étaient en déplacement, ne pouvaient plus aller vers les structures de soins pour prendre leurs ARV, mais aussi d'autres personnes vivant avec le VIH, notamment des populations clés, du fait de la double stigmatisation, avaient peur d'aller vers les structures de soins parce qu'ils avaient peur d'être infectés et ne voulaient plus aller vers les services. ça a été une situation assez compliquée et très vite, nous avons essayé au niveau de l'ANCS de mettre en place un système pour assurer la continuité des services, mais aussi assurer la résilience des populations, notamment des populations clés, des personnes vivant avec le VIH face à l'épidémie du Covid. Les mesures que l'État avait prises pour supporter ou accompagner les populations et les services étaient très en deçà des attentes des populations et nous avons vu très vite que les populations clés, les populations marginalisées étaient laissées en rade par rapport aux mesures d'accompagnement. Un exemple que je donne, quand il y a eu la direction de l'action sociale du ministère a commencé à dire aux populations, nous pouvons aider certaines personnes. Les populations clés qui se sont rapprochées des services de la direction sociale sont entendues dire, nous allons aider des ménages, des familles, mais nous n'allons pas aider des personnes individuelles. Alors vous voyez là qu'il y a une exclusion de fait de certaines catégories de population qui ne pouvaient accéder à aucune aide, à aucun accompagnement de l'État. Donc, l'ANCS a très vite élaboré aussi un plan de contingence pour les populations, notamment les populations clés. Nous avons aussi très vite mobilisé les communautés qui sont déjà mobilisées et qui sont déjà dans la lutte contre le VIH-Sida. Nous avons très vite demandé aux médiateurs qui étaient sur place, qui assuraient l'offre de services et la facilité d'accès aux services, avec, notamment pour les populations clés, de s'organiser, de faire en sorte que le traitement, la prise en charge, mais aussi l'accompagnement des personnes qui avaient besoin de services puisse continuer malgré l'épidémie du Covid. Et la stratégie des médiateurs, qui était une stratégie que nous avions mis en place déjà dans la riposte au VIH-Sida, nous l'avons utilisée pour que les médiateurs prennent les ARV au niveau des structures de prise en charge et aillent les distribuer aux personnes qui en avaient besoin au niveau communautaire pour assurer le traitement. Donc, cette stratégie-là, elle a consisté à faire d'abord un mapping des personnes qui étaient dans le besoin pour pouvoir les localiser, mais aussi identifier leurs besoins pour aller maintenant leur offrir les services. Ce que nous avons utilisé aussi comme stratégie, c'est l'utilisation de techniques informatiques, le téléphone, les GPS, etc., pour pouvoir localiser toutes les personnes qui étaient dans le besoin. Est-ce que je peux avoir la slide qui suit? Slide suivant, next, please. Next slide, please. OK. Donc, les médiateurs ont été mobilisés et ce sont ces médiateurs-là qui vont assurer l'offre de services au niveau de leur pairs. Ils avaient déjà la formation sur la dispensation des ARV au niveau communautaire. Donc, nous avons juste pris le dispositif qui existait déjà pour la riposte au VIH pour aller vers les communautés, notamment les communautés marginalisées, pour leur offrir le service. L'autre volet important dans la stratégie, c'était l'accompagnement pour la résilience des populations clés. Et là, nous avons distribué des kits alimentaires pour pouvoir les aider à rester chez eux et à pouvoir, en tout cas, continuer à faire le service. Parce que les mesures de confinement ont été très dures, notamment pour les travailleurs de sexe qui n'avaient plus la possibilité de sortir pour faire le travail, par exemple. Certains consommateurs de drogue aussi étaient confrontés à des situations où ils ne pouvaient plus sortir, donc aller vers la consommation de certains produits et les services qui offraient la méthadone étaient pratiquement fermés et ils se sont retrouvés comme ça dans des situations extrêmement difficiles et nous avons essayé, en tout cas avec la stratégie des médiateurs, à aller vers les populations et leur offrir le service de traitement et de prise en charge. Donc, les médiateurs ont eu à parcourir énormément de distances, de kilomètres pour aller offrir les ARV. Et ils ont réussi en tout cas à maintenir l'offre de services, à maintenir le traitement, à maintenir le soutien, malgré le fait que pratiquement tous les services publics étaient pratiquement paralysés et tout le personnel médical était mobilisé sur la COVID. Ce que nous retenons de cela en termes de leçons apprises, slide please. Bon, ça c'est des photos qui illustrent le travail des médiateurs. Je pense qu'on peut passer rapidement sur les leçons apprises pour terminer la présentation. Voilà, donc ce que nous retenons, c'est que le dispositif que nous avons mis en place dans la réponse au VIH-Sida a été flexible et adapté pour pouvoir répondre très rapidement à l'épidémie du Covid. Là où l'État n'arrive pas avec les communautés, nous avons la possibilité d'offrir des services, notamment aux populations qui étaient marginalisées et qui avaient des difficultés à accéder aux services. Nous retenons que le renforcement des systèmes communautaires est essentiel et fondamental pour que le système de santé puisse être efficace et pérenne. La contribution des communautés est une contribution qui va toujours au-delà des moyens et des capacités de l'État. Donc, il est important de continuer à soutenir et à mobiliser les communautés pour qu'ils puissent en tout cas faire en sorte que l'offre de services de santé puisse être accessible à tout le monde et au même pied d'égalité. Pour nous, la riposte communautaire est importante et la riposte communautaire est un pilier essentiel pour pouvoir en tout cas répondre à cette urgence épidémiologique du Covid. Si les communautés ne sont pas mobilisées, si les communautés ne sont pas engagées, si nous ne reconnaissons pas la valeur et l'expertise communautaire dans ce que nous sommes en train de faire, je pense que nous ne pourrons pas atteindre, en tout cas, limiter les dégâts du Covid. Voilà ce que je voulais dire très rapidement sur ce que nous avons pu faire avec cette stratégie-là, en attendant s'il y a d'éventuelles questions et commentaires. Je vous remercie.
Great, thank you. And thank you for all the efforts putting into having slides in French and in English, Masogi. We're very grateful. We've got some comments there that it's impressive to have slides in French and English. Thank you very much. And to time, so fantastic. So just to reiterate, your presentation very much identifies the important role that communities play and in community system strengthenings, the impact that has on strengthening the state's kind of response to not only HIV, but other health pandemics such as COVID-19. And I think certainly so lots of food for thought about, as we move forward in the future, how we continue to kind of bolster national health responses as communities. Thank you. So thirdly, it's my pleasure now to introduce Dr. Violet Nabat. She is the head of Pediatric and Adolescent Services at Mildmay Hospital in Uganda, part of the Pediatric Adolescent Treatment Africa, the PATA network. Dr. Violet is a pediatrician and is currently the head of Pediatric and Adolescent Services at Mildmay, Uganda, Mildmay Hospital in Uganda. And it's a great pleasure to welcome you to make your presentation. Over to you, Violet.
Thank you very much, Divya and Pradeep, for the introductions to this. Apologies about the video, but I want to take this opportunity to thank PATA for working very hard for expanding access to quality of care for children and their families that are affected by HIV. Looking at COVID-19 and the differentiated service delivery options for the adolescents. I am a frontline health provider, and this is my perspective in line with what PATA put together. So looking at building back better, we're looking at COVID-19 and saying this is an upcoming that has tried to overshadow the pre-existing. But we're grateful that we have been able to adapt through a number of interventions. And PATA took a survey at the beginning, and I'll give a bit of a summary of this survey as we go on. Next slide, please. Yeah, looking at COVID-19 and various lockdowns, these affected essential services heavily, especially in the sub-Saharan region where PATA operates. But we have high levels of HIV, TB, and malaria as the biggest disease burdens. But the region had to move from COVID-19 readiness to a COVID response. So the survey that we undertook initially was to check our readiness, and from that we needed to get to respond. And from the response, we had to get the service adaptations in place. So looking at the disease burden, we have 47 countries that are affected majorly with COVID-19, and looking at South Africa taking the lion's share of the infections, but several other countries have this infection as well. But how have we adapted? Next slide, please. In the PATA survey, we had 188 respondents from a number of countries, but most of the responses were from Southern Africa. And majority of respondents were involved in providing services for children, adolescents, and young people living with HIV. But all this was across the health system levels. We had the tertiary, the primary, and secondary, and 50% of these health systems were in the urban region. Next slide, please. We did an assessment to check what we needed at that point in the different health facilities. As you could see, 70% of respondents needed more information on COVID-19, and 24% reported not having received any SOP on how to prepare and respond to COVID-19. So looking at the breakdown of these, for resources to diagnose and care for COVID-19, the biggest majority said they needed more resources, and the highest number didn't have any at all. And then for prevention, they needed more. And again, a high majority didn't have any at all. So this showed that we were not ready to fight COVID-19 as it came in. Next slide, please. Looking at the readiness of the systems and the infrastructure, the biggest percentage were not ready in terms of the system and infrastructure in place, putting things like physical distancing, triaging of patients, SOPs in place. Many needed additional staff, additional space and beds. So it was really a state of emergency that needed to be fixed. But we are happy that as we speak now, there's a lot of adaptation that has happened. And then looking at other resources for usual care, we were managing HIV, we were looking at other chronic diseases, and we also needed essential drugs. So when we look at that, we still were in need of the ARVs to boost the situation, and then several other drugs to get us through the chronic disease management. Next slide, please. Looking at preparedness, and then what the adaptations that we picked up. The key considerations, we looked at coordination, training, and SOPs. And one of the adaptations that we had was we had to develop core teams that had to collaborate and a very good leadership. So this is the only way you would have a team sitting and saying, we need this type of SOP, we need this particular training to be able to have a team that is in place to fight COVID-19. Then considering staff capacity, of course, we looked at staff that needed to be trained, staff that needed to be given as much information as possible to pass on to the rest of the teams and to the clients that we were serving. And above all, they needed protection, especially for those at the front line. So this took adaptations for flexibility, contingency, and task shifting, procurement of PPE, and staff camping at work, because in several places, staff do not stay at the workplaces. But we had lockdowns in several countries, so staff had to camp at work, finish their section of the work, and then leave maybe a week or two later. Then we had to consider the number of non-essential visits to the clinic. As we run the clinics, we have clients coming in every time they come because they are assured that they are going to be seen by a clinician. But we had to limit this by reorganizing appointments and clinical management. We had to use telecommunications as well as consults to be able to manage the patient numbers even as they were home. We had to put infection control into consideration, and this, we had to do a lot of triaging. We had to ensure we have waiting room distancing, sanitizers in place, masks, and going paperless to minimize touching several surfaces. In terms of communications and messaging, we had posters, flyers, multimedia, mobile health, telecommunication again, and digital tracking, as well as tracing our clients to ensure that we are able to make sure our communication is really quite key for these people. But we also had to consider working with the community. Now, integration of community health worker systems was very, very important because this identified at-risk families and then linking them to food and social protection support. So these were major adaptations that were in support with COVID-19. Next slide, please. As we manage this differentiated service delivery, we have to consider the context, we have to consider specific populations, and then clinical characteristics. It's not a view of one shoe size fits all. So you had to look at the adolescents, then break them down. You're looking at that 10 to 14, you're looking at 15 to 19 to be able to manage them specifically. But even in there, it is a group that has different characteristics. There are some that are quite sick and then some that are really well. So how do you offer a service? We had to look into this and the particular specific populations, whether they were stable or unstable, for us to be able to manage the DSD model. Next slide, please. Next slide. Yeah, so as we continue with the DSD, we had to look at how we are going to do it and when. So we had to look at the different blocks and move them close. So our key takeaway in building back, we realized that there's a critical role for front health workers that they provide, standing up for their safety and protection and the resources and training needed for them to be able to manage. Let's not lose the gains already made. Essential HIV services and chronic care must not be compromised because we have an emergency that has come on board. But we also had to learn to do it differently. We have seen creative ways in differentiating services in a person-centered way, considering the different Ws on our model. Then mopping up, tracking and tracing every client. Definitely thinking through COVID and the lockdown, several clients may get lost along the way. So we have to track and trace through our records to ensure that we account for every client. Then there's need to capitalize on technology, mobile health systems, and virtual support systems for these people to be able to do it differently, but also involving our young people as we redefine, adapt, and shift service delivery platforms. Using the peer leaders is very, very key in this because they reach out to the community and then are able to maintain the link with the health facilities. Next slide, please. We thank all that contributed to the PATA survey and all health providers and peer supporters that were engaged in various products. Nothing for us without frontline health providers. Thank you very much, everyone.
Thank you, Violet, and thank you for such a comprehensive presentation. I mean, a lot of food for thought, and I think we all agree that the critical role that frontline health workers have played in the COVID-19 response has been quite tremendous, and it's so important that we think about how we ensure that they can work with safety and with all the equipment that they need in order to be able to continue the essential work services they provide to people living with HIV. And as you say, with a very much a person-centered framing of a differentiated service delivery. Thank you so much. So we're not going to open up for questions right now. We're going to save that to the end. But I think we want to now move on to the panel discussions that we'd like to have with not only our three presenters who are Violet, Masogi and Adit, but I'd like to invite three other panelists to join. Pradeep is one of them, so welcome back, Pradeep. And also I'd like to now introduce our two other panelists. Kali Lindsay, who is the LGBT portfolio lead at the Elton John AIDS Foundation. Welcome, Kali. Kylie Lindsay is driven by two things in his professional career: his belief in the inherent potential of human compassion and ingenuity throughout the world, and his passion for improved quality of life for all people living with HIV and human rights for all gay, lesbian, bisexual, and transgender men and women. He has held leadership roles with the former National Association of People with AIDS, NAPWA, Harlem United, NMAC, formerly the National Minority AIDS Council, and AMFA, as we know, the Foundation for AIDS Research, where his work focused on the development of PLHIV networks and civil society to drive demand in local and federal policy committees. In domestic and global AIDS efforts, sorry. He has also served alongside brilliant and fearless advocates on local and federal policy committees and boards of directors for NGOs. After more than a decade in public policy, Kylie has shifted his work to supporting civil society in achieving their goals through grant making. So welcome, Kylie. And I'd also like to introduce Joshua Taba. It's a great pleasure to welcome you too, Joshua. He's the Director General for Health and Nutrition in the Global Issues and Development Branch at Global Affairs Canada, and represents Canada on the boards of the Global Fund and the Global Financing Facility. He joined the Canadian International Development Agency in 2003 and has worked in several positions dealing with multilateral affairs and humanitarian assistance, including as head of aid for Colombia and Ecuador from 2008 to 2012 in Bogota, and as Counselor for Humanitarian Affairs at Canada's Permanent Mission in Geneva from 2012 to 2016. So welcome Kylie, Joshua and Pradeep to the panel discussion. I just wanted to ask the three of you what your initial reactions are to what you've heard during the presentations on the kind of HIV responses, adaptations to COVID.
Sure, I'm happy to start. I thought that those were really, really fantastic and smart presentations, and I really appreciate Masugi and Adit and Victoria for, Violet, I'm sorry, for their presentations this morning. You know, as I was sitting there, I'm reminded of the Greek philosopher who said necessity is the mother of invention. And it has been really, really impressive to watch all of the very rapid adaptations and innovations that have occurred in light of COVID. And one has to sit there and ask yourself, why now? Why have we been talking about these things for so long and have been able to, and have been, you know, historically not able to move them forward, at least not in the timeline that we hoped. But all of a sudden, when the COVID pandemic hit, we're all of a sudden in a position to be able to mount these innovations that we previously hadn't been able to consider. And one has to think about really the role that equality and population health really played in the decision-making practices that have occurred during this pandemic. And it has just been about really the biology of the coronavirus transmission, right? The COVID-19 virus just happens to be a virus that is very easily transmissible, that has very dire consequences if you're impacted. It shuts down the organs and could potentially be fatal. And there's no way to really know who has it, right? So it's not like HIV in that you only potentially can get it from individuals that are your sexual partners or individuals that you share needles with. But because, you know, there is such a risk of transmission, it broke down so many barriers to adaptation and innovation that have existed for a long time with HIV. And I think it really calls on us to really interrogate how we're making decisions and how we're really understanding what our role is as public health advocates, as public health providers, as frontline providers, and as community members, and really stamping out the threat and the disparities that exist for HIV. And it really is by taking a similar approach to how we've responded to the coronavirus and bringing it back into our HIV response. The ways that we have really mounted equal responses driven by data to the areas that are most in need, giving a standard package of services that is available to everyone to achieve a common outcome is all that we've been advocating for since the beginning of the epidemic. But for whatever reason, right, because of a variety of reasons that we can certainly talk about later, we tend to have different experiences for some populations and different experiences for other, which has kept us from ending the HIV pandemic that we know we have the tools and the resources to be able to do. So it really helps us to really put this all into perspective. If we can do this for the coronavirus, right, we can do this for HIV, and it'll be important for us to just take stock of the innovations and adaptations that have been possible in light of this pandemic, and really think about how we can bring those lessons learned and those successes back into our HIV response.
Thank you, Kali, and I really appreciate the sentiment around what have been the assets that we have built in these adaptations that we can actually then use when, if and when this particular COVID-19 situation moves on. We won't lose all those strengths and those experiences that we've had for the future. Thank you. Joshua, can I ask you for your reflections?
Of course, and Divya, thank you for the invitation to be with you today. It's really a pleasure to be with such a distinguished panel, and it's a great event, so thank you. I thought each of the panelists was excellent. A few of the themes that really resonated with me were the importance of relevance of focusing on community, the challenge of dealing with exclusion, and as well the importance of advocacy. I think each of our speakers this morning touched on those issues, and I'll come back to those as well. So I'll stay brief because I'll have a little bit more to say after, but for Dr. Violet, I was curious about whether those survey results are being shared with Dr. Moetti and the regional office of WHO, because that's really important community level information that we're not seeing enough of, frankly. And so great to know about the requirements, and hopefully solutions are going to be found in coordination with other actors there.
Can we see Violet? Does she want to respond?
Yes.
Did you want to reflect back?
Yeah. Thank you very much, Joshua, for that concern. But I am working with PATA just to ensure that this has moved out. Initially, we had to share the findings we got from the survey with UNICEF as a platform, but we're moving on to share it with all the other stakeholders because our report is out. And in working hand in hand with PATA, we'll be able to share this with other stakeholders. Thank you.
Okay, thank you. Great work.
Thank you, Joshua. And yeah, without further ado, over to Pradeep. Any reflections from your side on what you've heard from the presentations?
I think it's, I was sitting there listening to the three presentations. It brings out the best of what the AIDS movement is about. It's about innovation. It's about looking at opportunities and finding new ways of doing business. It's about empowerment. And one of the things which I've seen in the entire COVID response across countries is that where there is trust between the people who are delivering services and the community, the COVID response has been effective. And that is exactly what the three presentations, for me, that resonated very much. And for me also, I think, again, linking back to the AIDS movement, the whole decentralized response where communities are empowered, I think that is a model which works. And we have seen that in all three experiences referred to that. And I think for me also, I think when Violet spoke about not taking the eyes of HIV, because we should not let anything else replace HIV. It should be additionality. It should not be something which takes away. And that came through Adit's presentation also. So for me, it was, I was sitting there, I was just smiling and saying, wow, this is, so thank you so much. It's wonderful to hear that. And it's great to see that we are adapting to challenges and getting ahead of it. And again, you mentioned the whole issue of assets that have been built. When it comes to the crunch, it's these services, it's these capacities which are there as the front line of any health response, disease response. So thrilled.
Thank you. Thank you so much. Thank you for your reflections to all three of you. I'm going to move on to asking each one of you a question. And, you know, I think, as you've said, we've heard, you know, about some very critical examples of how the HIV response has adapted to COVID-19. And we want to now have a more of an open discussion about how we maintain these gains we made during COVID-19 and how the HIV response can strengthen the health system and the national emergency responses to health going forward. So very much in line with your reflections, everybody. But maybe if I could start with Adit. In your presentation, you said that you know, COVID has shown that community-led services and differentiated care is possible and enables greater uptake of services by people who inject drugs. So what's needed and what are the challenges to embed community-led responses within government decentralization policies and implementation? And how do you think that community-led services strengthen greater health integration within the health system?
Thanks, Sylvia. I think just to be clear, I mean, as a community, I mean, we've always been adapting to such a dynamic situation and environment, particularly in a very hostile environment where we are living in, with different policies taken in place, criminalization are everywhere against different key populations. I mean, we have to adapt, and then we have been doing that. And I guess for us from our community side, it doesn't take such a worldwide pandemic to actually realize that we need to adapt. I think it's already in our heart, and we know that we have to do this, and then we will always do that. I think that's really from our side. But as I mentioned in my presentation, I guess it's really an opportunity for us now to really make that case of how the community is really taking a very important role and not just, I mean, most of the time we're criticizing our government, but then at the same time we're also helping them in really reaching to people that they haven't really been able to reach. And I think that's really an important momentum that we need to be able to keep. I guess from here on, I think we would really need to strengthen ourselves in terms of getting evidence and data to be able to make that case, and really to have us as a community being recognized by particularly by the government.
Mm-hmm. Thank you. And just a reminder to everyone, if you have any questions, we'll be opening up for open discussion shortly. So please do share any questions you might have. Thank you, Adit. So to Masogi, if I can ask you, in your presentation, you talked about the community mediators, how they responded quickly and were able to address issues around COVID-19 with the people they were supporting and their families. So what have you learned about how the HIV response can add value to Senegal's national health emergency response? And, you know, I think if you can also talk about what's needed to make this happen in Senegal.
Merci beaucoup, Divya. Je pense que ce que nous avons appris face à la réponse au Covid dans un contexte d'urgence, c'est que forcément les expériences qui ont été bâties sur la riposte au VIH/SIDA ont été déterminants dans la réponse qu'on a fait contre le Covid. Je pense que les communautés, à force de travailler dans la réponse au VIH/SIDA, ont construit ou ont bâti un savoir-faire, un savoir-être et une compétence qui leur permet aujourd'hui de répondre dans l'urgence à des problèmes de santé. Quand l'épidémie du Covid a démarré au Sénégal, certaines personnes ont juste demandé au gouvernement de prendre l'architecture de la réponse au VIH/SIDA et de l'adapter à la réponse au Covid-19. Parce que le VIH/SIDA a su mobiliser les communautés, a renforcé leurs capacités. Et aujourd'hui, ce que nous constatons pour le Sénégal, mais même pour l'Afrique de l'Ouest de manière générale, c'est qu'il y a une expertise communautaire qui existe et qui, si elle est valorisée, peut être un pilier dans la réponse au Covid, mais même dans les autres problématiques de santé. Nous avons, pendant plus de 20 ans, appris à combattre les épidémies, le VIH-Sida, la tuberculose, le paludisme. Et cet ancrage communautaire-là a fait que nous avons aujourd'hui une capacité à répondre face aux situations d'urgence. Et cela a fait que très rapidement, quand tous les services publics étaient bloqués, quand tout le système de santé pensait au Covid, nous avons réussi et démontré que nous étions capables d'assurer l'offre de services, l'accès aux services, mais aussi de bâtir sur la résilience des populations les plus marginalisées pour qu'elles soient debout, parce que c'était important pour nous que tout le monde reste debout face au Covid, que la stigmatisation qui est faite sur les populations clés, que l'exclusion qui est faite sur ces populations-là ne vienne pas être un poids supplémentaire qui allait les faire tomber. Nous sommes ensemble avec ces populations-là, nous travaillons ensemble et nous avons réussi par ce mécanisme, cette innovation de taille, à faire en sorte que l'offre de services continue et que les populations qui sont dans d'autres maladies hors Covid puissent continuer à accéder aux services. Aujourd'hui, dans l'ensemble des programmes que nous avons, sur le trimestre passé, nous avions tous pensé qu'on allait avoir des problèmes de performance. Mais aujourd'hui, quand nous avons fait l'évaluation juste la semaine passée, tous les programmes sont performants. C'est-à-dire que nous avons réussi à atteindre nos objectifs en matière de prise en charge, en matière de nombre de personnes qui sont sous traitement et qui continuent de l'avoir. D'autres innovations de taille actuellement sont en train d'être faites. La mesure de la charge virale, par exemple, aujourd'hui, ce que les médiateurs sont en train de faire, c'est de rassembler les personnes qui sont dans des coins reculés, qui ont des problèmes pour se déplacer, faire la collecte des prélèvements, les amener au laboratoire, faire la mesure de la charge virale et revenir pour leur donner les résultats de charge virale. Donc ça aussi, c'est des choses extrêmement importantes qui sont en train d'être faites. L'utilisation de plateformes informatiques aussi par les médiateurs pour pouvoir contacter les personnes, donner des orientations et des informations pour lutter contre la COVID. Ça, c'est véritablement des choses qui sont en train d'être faites. Et je pense que ce qu'il faudrait pour que ça puisse continuer, c'est de reconnaître d'abord au niveau de l'État l'expertise communautaire, de la valoriser, mais aussi de soutenir les actions avec des financements pérennes qui peuvent permettre aux communautés, en tout cas, de continuer à faire ces innovations-là et à s'adapter aux difficultés des contextes d'urgence et de la faiblesse des systèmes de santé africains, qui fait que si les systèmes de santé africains n'impliquent pas les communautés, je pense qu'ils vont avoir du mal à répondre de ces épidémies qui nous arrivent comme ça et que nous avons du mal à gérer.
Thank you, Masogi. Thank you. I'm conscious of time, and I think we maybe won't have time for a Q&A at the end, so I'll just carry on if I may. So Dr. Violet, so we've heard from many people about the disproportionate impact that COVID-19 has had on women, both in terms of women experiencing increased levels of domestic violence and increased caregiving responsibilities. And we've heard that globally about 70% of the formal health workforce are women. What did you learn about the intersection of being at the front line of health provision and also ensuring that your own team's health, well-being and mental well-being was taken care of? What is your reflection about how gender needs to be addressed during future crises? I wondered, Dr. Violet's, whether she's still there.
Yes, I am.
Oh, you're there. We look like you dropped off. I'm relieved. So did you
have
a question?
Yeah, thank you very much, Divya, for that question. But you and I know that majority of frontline health providers, nurses and community health workers are women, and these are by far the most directly affected by COVID. Now, during the Patel survey, we actually picked out that there were high levels, extremely high levels of anxiety and fear that were being experienced by those on the front line. And this fear was about one's own health. Will I get infected as I take care of patients? And that of exposing family and loved ones, and very real concerns about the ability of our health systems being able to protect its staff and provide the necessary PPE, infection control, health and safety. So you're looking at a woman who is leaving her home. There's a husband who is not working, the children are not in school, they're at home, and she's going to take care of individuals. She doesn't know if she's being exposed to COVID-19, and she's worried about her own health, but she has to get home as well at the end of the day. There are children that are going to welcome her. There's a husband that's waiting at home. So there's fear of having them infected and how we are going to manage this. So looking at the fact that still in the survey, there were a lot of needs for PPE, for infection control, health and safety generally, and as well as several other issues to come by. So we actually realized that the health providers were under immense mental strain during these times. And we had to come up with debriefing platforms. PATA was very, very important because it came up with that. But we also realized that the team leads had to meet the staff quite often to hear them out, to listen to their anxieties, to support them and ask for their needs through and through until now, because we always have those meetings just to ensure that we are helping them, we are supporting them, and helping them run their families as well. However, we also noted that transport was a big problem. So in several units, the unit had to come up with means of transporting the staff, including having them reside at the health facility to do their work, and then at the end of the time of their shift, they have to get home. Now, looking at violence majorly, of course, we are hearing several reports across the region of increased GBV. And for many women, lockdown limits their abilities to seek support from friends or family, with women often being locked down with a perpetrator of violence. In most of our families, we are not used to husband and wife being together all the time. But this is a circumstance where they ended up staying together. And this is when they end up picking up small quarrels here and there and fighting as well. Of course, it's the woman that suffers in all this. And this really placed women at risk. And a few countries in our region have the capacity to respond effectively or provide necessary emergency or crisis support. But there's also limited opportunity during these times for the women facing violence to leave the home or to leave to a safer place, because there's no such space for now. The rule is stay at home. So you're staying in there with the perpetrator and you just cannot move. But we trust and believe that our governments and community organizations must invest more in crisis centers, emergency accommodation for staff, and provide the necessary mental and physical support, as well as legal protection for women experiencing violence. Thank you.
Thank you, Violet. Very critical area there that you've just mentioned. Time is slipping away with us, and we still have to ask our other three esteemed panelists some questions. So let me move on to Joshua. Joshua, can you share with us what you have learned from the response to COVID-19 that will help us build back better and strengthen integration across national health and emergency responses? What do you see as the added value of the HIV response to these broader responses going forward?
Thanks, Divya. And what I'm going to say is actually going to build very nicely on what Dr. Violet was just sharing with us. So let me highlight three things. So one of the key things that we're learning is about the fragility of health systems around the world. We're seeing that even when level 3 hospitals are effective at managing a surge and implementing their contingency plans, where we're really seeing limited capacity is at the front line and community health systems. That's where breakdowns are happening. That's where we're missing people. So part of that added value of what we've learned through HIV response is knowing how to reach key populations. Part of this is identifying who's being missed at a community level, but I think more importantly is understanding why they're being missed. What are those barriers to services? Are those barriers systemic, structural, specific? Ultimately, whether it's the HIV epidemic or the COVID pandemic, we need to reach everyone who needs it with strategies for prevention, treatment, and long-term solutions. So part of this is ensuring that our health systems work for the most vulnerable at community level, and that means greater investments in health system strengthening. We all know this. But that has to be both to react to infectious diseases and outbreaks like this one, but also to ensure the underlying resilience and capacity to maintain core programs. And these investments have to reach that community level resilience. So we know that we can scale up high-tech diagnostic machines and capitals relatively easily. WHO and Global Fund have been putting them in. But what we can't build quickly is capability at the frontline and community level. And that's going to be an ongoing project for all of us after this, because we have to be able to both respond to the epidemic while maintain our HIV/AIDS services, just like those for nutrition or SRHR, maternal and newborn health. So that to me is the first key lesson. The second key lesson is that we're reminded that we have to ensure that our response doesn't exacerbate or perpetuate gender and health inequalities. We know, as Dr. Violet was just saying, that women make up the significant majority of frontline health workers and caregivers. So they carry that additional burden and that risk of both their paid and unpaid work at the front lines of this pandemic. And we know that these lockdowns we know that the lockdowns are exacerbating inequalities and vulnerabilities. For example, we're learning about surges in gender-based intimate partner violence and in early and forced marriage. We know that the loss of livelihoods, fewer employment opportunities is leading to an increase in transactional sex, in sex work, and sexual exploitation that puts people at risk both of contracting HIV and of COVID-19 unless they have the means to protect themselves, and that's not being prioritized sufficiently. And then finally, it's reminding us again how important voice and representation are. You know, our work with organizations like the Global Fund show that early, ongoing engagement with affected communities and key populations is really a key factor in the success of HIV programs, and that complements the broader work we might have to do around policy and architecture. So we have to continue to find innovative ways to amplify, support, replicate the successes that are emerging from affected communities themselves so that we can continuously improve program delivery. And in that sense, as this COVID-19 crisis continues and we begin to focus more on adapting to the disease, community-led interventions and monitoring are going to be key. As we learn more about COVID-19 transmission and treatment, we can draw from our experience on HIV to ensure strong focus on human rights, preventing stigma, discrimination, harm reduction, inclusion of key populations, and also ensuring complementarity where appropriate so that we're integrating HIV response and prevention into our pandemic response efforts. So that's why including key populations experiencing marginalization, vulnerability in the decision-making spaces around COVID-19 is going to be so crucial, not only so their needs and priorities are addressed, but also to ensure that the overall response is effective. So just to say, Canada's committed to work on these issues and to use the platforms that we have to amplify the lessons we're talking about today. Thanks.
Thanks, Joshua. Thank you. So moving on to asking Kali, your experience sits on the intersection of public policy, LGBT rights, and grant making, amongst many other things. From your view, what opportunities have opened up because of COVID-19? I mean, it's strange to use the word opportunities, but I think you know what I mean. And how do you see investments in the HIV response as critical for ensuring that no one is left behind in our pursuit of universal health coverage and the SDGs?
Thank you for that question. You know, this has been an incredibly inspiring conversation, I must say, and I'm happy to go following Joshua because I think I will build off of a lot of what he said in his remarks. You know, the one thing that I enjoy doing at times like these is just recognizing, as Pradeep started out at the beginning of this conversation, that we have so much history in our HIV work, and we're really standing on the shoulders of giants, right? And one of the giants that I often think about in the work that I do in HIV, whether in the United States or globally, is I think about the author, poet, and activist James Baldwin and his words at times like these. And if you all don't mind, I'll share one quote with him that everybody might not be familiar with. And I'm going to use America, but you can take out America and insert whatever country of your choosing. But he says that, "I love America more than any other country in the world. And exactly for this reason, I insist on the right to criticize her perpetually. I think all theories are suspect, that the finest principles may have to be modified, or may even be pulverized by the demands of life. And that one must find, therefore, one's own moral center and move through the world hoping that this center will guide one right." And I think COVID-19 has reminded us that there is an opportunity here again for us to revisit our principles, our policies, our programs, and our societies and ask ourselves again, what needs to be rethought? what do we need to change in order to really pursue the goals of universal healthcare and the Sustainable Development Goals, not only for those that are most available and accessible in society, but also for those that are most marginalized and oppressed in society. And we know that we've done a lot over the course of the last 40 years to mount very targeted and tailored responses that work for many communities. But we know in light of COVID-19 that many communities are still being blamed for the pandemic. They're being isolated from COVID prevention and treatment opportunities, and their needs and priorities are not being listened to, valued, or concerned. And that is really the role of public policy. It has been the role of public policy since the beginning of the HIV pandemic. It is the role of public policy in light of the COVID pandemic, and it will be our role as we consider what opportunities exist for universal health coverage and the Sustainable Development Goals. And that is, as Pradeep started us with, the pursuit of equity for all people everywhere, leaving no one behind. And, you know, we get tied up sometimes in this conversation between equity and equality. What we're reaching for and striving for is equity. And we probably spend too much time talking about disparities and not enough time talking about equity. But our goal is not to just alleviate disparities, it's to achieve equity for everyone, everywhere. And in order to achieve equity, we need equality in the delivery of our programs and services. And I think when we deliver COVID prevention and care and treatment responses, right, we need to interrogate every part of that effort that we're mounting and determine whether or not we're achieving equity in the way that we're providing services to individuals that might be in the mainstream parts of society and individuals that we might not be seeing, right, and coming into offices who may not have transportation, as one of our presenters talked about, who may have different experiences because they have substance use issues, or maybe experiencing intimate partner violence, but not having that recognized as intimate partner violence because their relationships aren't recognized by the state. But it doesn't mean that their needs are different. What it means is that they are not part of the prioritization of how we're delivering our response, which means that we need to develop new standards that achieve equity, that achieve equality, so that we can achieve equity in our health outcomes rather than disparities. And we also need to continue to listen, mobilize, and support and invest in community-based organizations and civil society groups, because they are at the intersection of how communities and governments prioritize their lives, as James Baldwin says, and the way that resources and policies are promoted from multilateral and bilateral organizations, as well as from the promulgation of policies related to universal health coverage. And if we are to achieve a world or a response that has healthcare quality and accountability front and center, then one of the ways that we must do that is by making sure that we look at what standards of care are available to all people in all parts of the country. And we have to ensure that we're not just paying lip service and saying that we don't want to leave anyone behind. But if we don't see that people who use drugs are getting the necessary methadone that they need, and we can adapt differentiated and decentralized service delivery, that needs to be a standard of care. That's not an emergency response, that's a humanitarian and a moral response. And we can't lose that just because we're in this crisis moment. We need to remember that these are humanitarian responses that need to be part of how we deliver healthcare and how we deliver public health in our country, in every country, where anyone is impacted by any kind of infectious disease. And I think that's the lesson that we bring back in thinking about our work historically to address the HIV pandemic, to advance LGBT rights and human rights for everyone, and to really make sure that this world creates an equal opportunity and leaves no patients behind.
Thank you. Wow, I got very moved by your intervention. Thank you so much. And I really do hear what you're saying around how, as we move away from this emergency situation, that the kinds of approaches and the community-led involvement becomes a standard of care. It isn't just to fix an emergency situation. I hear that loud and clear. Thank you so much, Kali. So finally to Pradeep. I know we're over time, but please bear with us. Pradeep, you know, UNAIDS is supporting the acceleration of innovation, and that's the area that you're looking at the moment, within the HIV response and the broader health issues connecting innovators, investors, and governments. What is your advice for how community-based HIV actors can engage with other innovators, investors, and their governments to take their COVID-19 adaptations and innovations to scale.
Thank you very much. Maybe there are 2 or 3 things which I'm really focused on. One is as part of the COVID response, every foundation, every donor, everybody is putting huge amounts of money to respond to COVID, which is fantastic. But what is not happening enough is to invest in what is already existing. And everybody wants to create that shiny new platform and new ways of investing that. I think we need to really see how the community investments, and again, if you look at the AIDS movement and the communities, if you look at the capacities on a scale, it's the AIDS movement which has it on the ground when it comes to community capacities. When it comes to trust, it's the largest body of trust that exists. If you look at the ability to scale, I can't think of any other movement that has community responses on the scale. If you look at resilience, despite the ups and downs, the communities have stayed the course. And we have seen now that the communities also are innovating. So I have 2 or 3 things in terms of where I see opportunities. One is, I do think that we need to really start thinking much bigger than what we have thought so far. If you look at the overall ODA last year was just below $150 billion. But if you look at the overall equity market, if you look at the investment market, that's about 300 trillion. As long as we focus only on this 150 billion, of which probably about 26, 27 billion is held, as long as we are just limited to that, we will never be able to get to the scale to prevent future pandemics and also deliver the services that we need to deliver for existing health challenges. So one is, I do believe that we need to be much more active in leveraging the ODA to bring in the private equity funding, private money into the health sector, which I do see huge potential. Number 2, most of the social innovations, including the examples that we heard today, I don't think anybody is focusing enough on packaging it and presenting it to investors in a way that there are small social impact investments that are happening, but we need to, as I would say, international partners, we need to be much more active in packaging these as absolutely impactful. We need to look at what the impact has been, what this absence of some of these responses would be, and to present it as investment opportunities. And we haven't done enough of that. We have been trying to do some of that, but it's still a huge challenge. Number 3 for me is the role that we play at UNAIDS, the Health Innovation Exchange. If you just Google Health Innovation Exchange, UNAIDS, you will find it. What we have really done is to bridge, I know one of the questions that came was about political engagement. What we really are doing is finding the pain points for ministers of health, working with the innovations community to bridge that and to bring investors to make it a viable investment. And very happy to carry on these conversations. If I may say one other thing, because I work on technology quite a lot, and on COVID, I'm seeing something, a trend which I'm worried about, although I'm a huge technology fan. I think the AIDS community, the AIDS movement has to keep an eye on what is happening with the use of technology with COVID. I think the tracking apps that are being developed for COVID, which are being implemented on a large scale, that might come to bite us, because that will eventually become a way of discrimination into the future. But I won't go into the details here, but I'm seeing a lot of that happening, and that's where I think the AIDS movement has to keep human rights, equity, and accountability as its fundamental continued role in the health space. I'll stop there.
Thank you, Pradeep. And I think we should all heed your words of warning. I think it has also, yes, what could be a help in a particular context may actually serve to bite us in other ways. So, but thank you for such, Chrissy says here, Christine Stegling-Aridi, thank you for such a rich and insightful discussion. I really think it has been. And apologies, my chairing, despite my best efforts, meant that we were short of time for the questions and answers. So I don't know, I think maybe we should probably wrap up. And apologies to those of you that did send a question. We will try and answer that afterwards. But really, if I can thank you all so much. Such wonderful panelists, such rich presentations, so much food for thought. And And as I wrap up, I think what I'm left with is really thinking, I'm really humbled by the achievements and the successes of the HIV response. You know, sounds a bit self-congratulatory, but I feel like we do need to applaud ourselves sometimes. You know, we have been so resilient, adaptable, quickly adapting whatever resources we have to respond to COVID-19, particularly for marginalized and key populations. I think we take it a bit for granted, but it's true, like within a matter of weeks, days, we were quickly able, and communities were quickly able to adapt and adjust. And I think for us as well, it's moving beyond the theory. We've actually really proven to ourselves and hopefully to others that it is possible to reach marginalized and key populations, ensuring that they're not left behind as universal health coverage and the SDG agenda gets more and more prominent. You know, we've tried it out with COVID-19, and I think we can show to governments that when you work with communities, you can really draw on that community expertise to bring about the equitable standards of care that Kylie, you mentioned. You know, it's not just a knee-jerk reaction to an emergency, but actually something that can become standardized. And when it's to build back better. And really that COVID-19 is an opportunity to reiterate the principles of equality for everyone. Like we've been advocating right from the beginning of the HIV response, and you know, and not just for, but with and led by communities themselves. And of course, last but not least, we must try to ensure, and you know, Pradeep, your eye-watering figures of how many trillion seem like a world away. But you know, it's important to invest in communities. Those investments in communities are absolutely critical to reach scale to the degree that you were describing, and for these innovations to continue, because as these unknown uncertainties prevail, communities will have to continue to adapt and strengthen the national health responses to these emergencies.
Yeah.
Thank you so much. Lots of food for thought, and sorry that we couldn't open up to the group for you know, for any questions, but yeah, I think it's time to close shop now. Thank you so much, everyone. Bye.
Thank you. Bye.
Bye.